from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we're learning about endometriosis. Our guest today is Dr. Kyle Garner, a gynecologist here in Sarasota. Dr. Garner, thank you for joining us.
It's my pleasure. I've enjoyed being here.
So to start, what is endometriosis?
So endometriosis is a common disease that women experience where the endometrial tissue that normally is confined inside the uterus begins to spread outside the uterus and grow in other parts of our body. The most common place, of course, is inside the pelvis, usually in the space between the uterus and the bladder or behind the uterus and in the rectal area. And because of its development, it begins to cause symptoms.
How common is endometriosis?
It's pretty common. About 10% of women, so 1 out of 10, basically will experience some form of endometriosis in their lifetime. The severity is extremely broad, and that's kind of one of the interesting things that makes it difficult to pick up. Patients who can have very severe disease but have minimal symptoms. Patients may have very minimal disease but very severe symptoms.
So what are the common symptoms of endometriosis that women should be on the lookout for?
Most common being cyclic pelvic pain. That's where, during the menstrual cycle, where the hormones are ebbing and flowing through the normal process of their physiology, they may begin to experience pain. The classic is after ovulation, kind of in the midpoint of their cycle and leading up to when their period begins, they begin to experience more pain. They describe it as either pain, like crampy pain. They may describe it as bladder pain, difficulty with their bladder function. They may feel it painful with their bowel movements or even with intercourse. That's where it gets worse and worse and worse leading up to the cycle. And then it typically has a break right after the period begins. And they may be pain-free for a little while. So it kind of ebbs and flows. As the disease gets more severe, though, the symptoms may become more consistent, and they may have them throughout the month, even daily, particularly if the disease begins to affect other organs, causing damage, scar tissue, those kinds of things.
What symptoms tend to surprise patients the most?
A lot of women think that the pain is primarily driven by the uterus. They expect it to be a uterine pain or ovarian pain. And I think what's surprising is that it involves so many other structures. Endometriosis, depending on the type, can be a very invasive disease. It can actually invade into other structures of our pelvis. It can invade into the bladder, it can invade into the nerves and muscles and surrounding tissues in the pelvis. So some of the disease symptoms may reflect those areas. Patient may get almost muscle pain. They may get thigh or nerve pain in their thighs because of the endometriosis involvement. And the depth of invasion makes that more severe.
So when should someone seek evaluation? And what should they do if their pain isn't being taken seriously?
Well, I think that's an excellent question. One of the big problems that women face is that many times they're not diagnosed in a timely fashion. Many women may suffer from the pain of endometriosis for 4 to 10 years before they are actually diagnosed. It's important that, number one, the patients be an advocate to themselves and with their provider to talk about their symptoms and really review it with them. I think physicians need to be more attuned to the evaluation of the pain and an aggressive management of that pain to ensure that it gets taken care of. I don't think it's appropriate that women just accept pain as part of the natural cycle. Yes, there's always a little bit of mild cramping. Yes, there may be heavy periods and those kinds of things. But more importantly, it's the severity of the symptoms. If they get worse over time, if they're beginning to affect your life, affect your relationships, you need to pursue it, and physicians need to pay attention to that.
So what tests or tools are used to actually diagnose endometriosis?
Well, the first, of course, is an ultrasound. That's one of the best modalities for evaluation. There are certain features that we may see, the development of things like ovarian cysts. We can determine whether or not the pelvic structures move in the appropriate way, whether there's fixation or scar tissue. And ultrasound is a non-invasive, relatively quick procedure that can be done and give us a lot of clinical information. MRI is kind of the next step in the evaluation of chronic pain and when patients have maybe confusing symptoms, because it shows a deeper evaluation of the pelvic structures and can help to highlight both the involvement of the uterus or other of the deeper pelvic structures that we talked about, muscles and nerves and that deep involvement. Ultimately, though, it's a surgical evaluation because, as I said earlier, the severity of the disease may not necessarily reflect the symptoms. And so ultimately, surgery is going to be necessary to really look and evaluate whether or not the disease is present and how to treat it.
What does long-term treatment look like? Because endometriosis, from my understanding, is not something that maybe you have it surgically treated once and it may recur.
Correct. It really is a multimodal approach. The primary way of treating endometriosis is hormonal. And actually, that's one of the ways that we can make the diagnosis early on, particularly in adolescence, is their response to birth control pills. Birth control pills give the combination of estrogen and progesterone in a continuous fashion, which helps to treat the endometriosis. Endometriosis is primarily driven by estrogen, and progesterone counteracts that. So that's one of the mainstays of therapy. We can use not just birth control pills, but also high-dose progestin therapy, and we can use more strong medications like the GnRH agonists and antagonists, which really aggressively suppress the growth of endometriosis. Like I said before, though, it's multimodal. Surgery combined with hormones may help really provide the longest term relief for those patients who are particularly severely affected.
Is it possible you'll need more than one surgery? And what does surgery look like?
So surgery is typically laparoscopic. We either do it through traditional straight stick laparoscopy or use the robot to be able to go in and ultimately resect the areas of endometriosis. The complexity of the surgery really depends on your severity. Early stage 1 or stage 2 endometriosis, which is more superficial in nature, that can be excised or cut out easily. We can sometimes use electrical or laser therapy to burn it off superficially, and that helps to minimize the symptoms. Deeply invasive surgery or deeply invasive endometriosis typically requires more invasive surgery and the resection of other tissues because it can involve other things, again, like nerves, bladder, ureters, and it can be pretty severe.
What does recovery look like from surgery for those patients?
Recovery is usually pretty good. Many of these patients can be treated as an outpatient, meaning that they can have surgery that day and then go home the same afternoon and be back on their feet within a few weeks. Again, it depends on what all needs to be done in the surgery, but many times my patients in particular are able to go back to work within a couple of weeks and their symptoms are dramatically improved.
When do you decide with your patient it's time for surgery? We're not even going to try other methods. When is surgery the right call, or do you try medicines first? How does that work?
That's a great question. I'm always one to try medical therapy first because we know that surgery always is fraught with potential risks, particularly with things like endometriosis where other organs may be involved. When you are trying to remove that endometriosis, you run the risk of injuring those organs. So medical therapy really becomes the primary way of treatment. I will offer patients a birth control pill, continuous pills where they don't cycle, or even going to some of these newer medications like the GnRH agonists and see how they respond. One of the most important things, though, is that you want them to respond. You want their pain to get better. If they aren't getting better, if the pain persists or you're not seeing the kind of response that you would expect clinically, I think then it's time to talk about proceeding with surgery.
How does endometriosis affect fertility?
The severity of fertility or infertility is dependent on a couple of important factors. Number one is the alteration of anatomy. Because of the inflammation associated with endometriosis, patients can have scar tissue form or damage to their fallopian tubes. That's the primary way that patients may suffer infertility. If the tubes are damaged, then the egg and sperm can't get together and fertilization can't occur. So that becomes a problem for patients. But endometriosis also causes a change in the environment inside the pelvis as well as inside the uterus. There are a lot of inflammatory mediators, cytokines and prostaglandins, which affect the uterus and the tubes and their ability to allow for fertilization and implantation to occur. So it is complex and really isn't just related to these kinds of scar tissue issues, but patients with endometriosis may suffer infertility even when their tubes are open.
Can someone with endometriosis still get pregnant naturally?
Absolutely, absolutely. It is actually a great treatment for endometriosis. That's one of the things, again, is that endometriosis is primarily a disease of estrogen. And in pregnancy, patients have a lot of progesterone. That's the treatment for endometriosis. So many times after pregnancy, patients will see their endometriosis symptoms get better. And so that's a great opportunity for patients. But yes, they're absolutely able to conceive. It does require physicians to make sure they pay attention to the time that, typical couples to try and conceive may take a year or so. Endometriosis patients may take a little longer. If they aren't able to conceive in that time, then I think it's important that physicians start to pay attention and work the patient up for infertility issues.
What do you think is the biggest misconception about endometriosis that you'd like to clear up?
I have a lot of patients who kind of come to me with complaints of pain and they kind of have accepted it over the years. And they talk about their mom had it and their parents have it. And maybe some doctor along the way told them that they have endometriosis and they kind of just accept it. I think it's important not to just accept it. If the symptoms are bothersome, then you have to recognize this is a disease that may affect your health. And if this disease is getting worse, if your symptoms are getting worse, I don't think patients should live with it. I think they should pursue a doctor who wants to take care of them, to treat them appropriately, and try to make a difference in their life.
Are there long-term risks with leaving endometriosis untreated, aside from just being uncomfortable? Can it cause something else, something worse?
Yes, so there is a slight association with malignancy risk. As again, I said, endometriosis is an inflammatory disease, and we know that inflammation can increase a person's risk for cancer. Endometriosis, because it's endometrial tissue, it can theoretically cause an endometrial type carcinoma in the ovaries or in the pelvis, and so we need to be aware of that. There is a rare association with progression of disease in menopause, particularly in women who take hormone replacement. So being aware of those symptoms in menopause as you progress. We do feel, again, that endometrial cancer, again, actually inside the uterus itself may be increased as well with patients in endometriosis. So definitely report any of the strange symptoms, abnormal bleeding, postmenopausal bleeding, other chronic pelvic pain, again, a reason to be evaluated.
What would you say to one of your patients who has been living with this pain and says, well, I don't want to take birth control pills, or I don't want to take hormones, and I don't want to go through surgery. I think that might be worse. How do you help your patients deal with long-term pain and these risks versus the fear of whatever treatment would be?
I think it's just patience and education. That's really the best thing to do. I don't really push my patients to one treatment modality or another. I really try and encourage them to find their own pathway. We all have different pathways in life and what we feel comfortable with. I will encourage patients to even pursue other kind of non-traditional therapies, things like acupuncture and herbal therapies. There is some evidence that it works in patients as well. So you have to find the pathway that fits you. But again, as I said, patients also have to understand that over time, particularly if they do truly have endometriosis, if they are continuing to cycle, if they're continuing to have a normal menstrual cycle, they will see their disease potentially progress. And that progression is going to lead to more symptoms, make it more complicated to treat, particularly again in a surgical realm. And that affects their life and spills over into the other parts of their life, which really become debilitating.
Are there lifestyle changes you recommend as well for patients with endometriosis?
Absolutely. I think it's important, again, to come back to the traditional things that doctors have always said, which is, eat right, exercise, get good sleep. Those are important things. Cutting alcohol, cutting tobacco, all seem to help with the pain management component of endometriosis. That's the primary thing. It's really the pain component that is best treated with exercise, stretching, nutrition. Once the disease, though, has begun to alter the anatomic structure, it becomes harder to treat in these conservative ways, and really, ultimately, that's where surgery plays a role.
Is there anything else you want to add today?
I think there's a lot of stigma and maybe fear associated with endometriosis. I think that patients sometimes may feel shame associated with it because it is this prevalent thing that is talked about on the social media and infertility and the struggles that women get. I just want people to be honest with their physicians, to report their symptoms, and have an open mind to being treated for it. I think physicians also need to really pay attention to patients' symptomatology and not just blow them off. And I've heard that story too many times, that patients have struggled talking to multiple physicians many times before they finally find a physician who's willing to listen and talk about the different kinds of therapies that they feel comfortable with.
Dr. Garner, thank you for answering all these questions today.
It's my pleasure.
If you liked this episode of HealthCasts, please like and comment and visit smh.com/podcast to hear other experts like Dr. Garner talking about the health issues which matter to you. As always, we encourage everyone in the community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.